Yeah, I know that I have 12 o'clock noon, so we will go ahead and get started today. I'm Becky Royer with the Indiana Hospital Association and subcontracted by the State Office of Rural Health for the Medicare Beneficiary Quality Improvement Project work. And through that, we provide a monthly swingbed education program where we hit on various topics related to having a really solid swingbed program, both from a compliance and a revenue generating department for the hospital. So Carrie Dunning is our swingbed consultant who does a lot of work on a national basis with many critical access hospitals across the country and has also conducted some international work around long-term care. So she's very, very knowledgeable about swingbed programs. So even if you have questions that aren't related to today's topic, please send those our way and we will be glad to get them answered. Our focus topic today for the month of August is trauma-informed care. A few months back, we talked a little bit about trauma-informed care at that time, but bringing it up again, because as I've talked with hospitals across the state, this seems to be an area where true solid implementation of really having trauma-informed staff and knowing what the proper processes are and how to deal with those individuals that have experienced trauma in their life has been difficult to really kind of put your hands around. So Carrie's going to talk a little more about trauma-informed care today. And I do encourage you to ask questions as we go. And by doing that, you can hover at the bottom of your screen and there's a microphone icon that you can click to unmute yourself. We encourage you to have your camera on if at all possible too. You also in chat, if you hover at the bottom of the screen, there's a chat icon there as well. I monitor chat throughout the program and will ask any question that you insert into chat or any comment. Likewise, it's nice to click on the participant button too, so that you can see what other hospitals are on. And sometimes it's a nice way to connect with people you probably haven't seen in a long time because of COVID. So encourage you to do that. We do ask that you put your name and your hospital in chat so that we can capture an accurate attendance. We can see some names in the participant list, but sometimes there's more than one person in the room, or you may be logging on to someone else's Zoom account. So it's kind of nice to have that information in chat as well. So Carrie, I'll go ahead and turn it over to you and we'll begin today's program.
I appreciate it, Becky, and Allie, I appreciate your assistance. You have taught me so much. I'm not quite as illiterate with presentations because of you, so greatly appreciated. You notice on this kind of cover screen, I want to make sure that if your hospital owns a long-term care facility and or a skilled nursing facility, or if long-term care and SNF are in the same building, they're under the same rules that we are talking about. So we are going to center in on swing beds on purpose. But I want you to know this isn't an isolated incidence for this. This is all of skilled care must do this. The important thing too, I need to say up front is for you to understand that I have no proprietary interest in anything, instrument, device, service, material, during this, and that's because there's so much going on with long-term care right now and the isolation issues and other things that are happening that I want to make sure that you understand this material is for your purposes and knowledge. One of the things that keeps catching me short, and this is why Becky and I started talking about this probably 8-9 months ago, but actually the deadline to implement a full-fledged program for trauma-informed care and the attached requirements for culturally competent staff was October of 2018. Long-term care facilities and SNFs had to comply by November 29 of 2019. It's really unusual that this was reversed. It's usually long-term care SNF that gets the first and then swing beds follow. So this was purposefully directed at swing beds in 2018, which means now as surveys are picking up and there's more discussion about it, this is going to be a pretty seriously reviewed area. If you haven't done sort of the full bore program, then you really want to show that you are starting it and you are have a comprehensive plan on how you're going to deal with it. So it is one where we want to make sure that because of people, and that can be staff or patients, have had trauma in their lives, that our staff is competent in understanding cultural differences and being able to recognize triggers that may cause re-traumatization. But the same is for the staff. If they are working with a patient that sets off something in them, reminds them, even subconsciously, of anything that they've had in their past, then it's re-traumatization for staff, and then the back and forth between the patient, it can just keep going on and on. So that's why you have to train all staff involved with your swing bed program. And we're going to talk about that again in a minute, but think about that. That's dietary staff, that's housekeeping staff, that's potentially maintenance staff, that's your administration. It is literally everyone. And you need to make sure that even though this is for skilled care, skilled nursing settings at this point, that anyone that comes in contact with a swing bed program, or if you own a nursing home, has to go through the training. I have the federal regulation number there, the 483.25. It is in section M or subsection M. The F-tag, if you're not aware, F-tag is a federal tag, which means that if you are not in compliance with the rules that we're going to talk about, they can tag you not only with 699, but the way surveys are going these days, there are subsets of that. Almost always a primary tag, in this case, talking about trauma-informed care, and the 699 go to subsets that go to quality and safety federal tags. Those federal tags, the importance to you is you can be surveyed and are being surveyed by state surveys, but you can also be surveyed by federal survey teams, and any of that can lead to fines and or requirements for correction of issues. So I want you to understand that this has sort of a snowball effect. Once you roll this downhill, it keeps going. The main place where you would capture this information, honestly, for an individual patient is going to be first on that baseline care plan, and then how you fill it out with a more appropriate care plan, as you learn more about the patient. So that comprehensive assessment, and then doing an individualized plan of care for all of your admissions will be one of the things that any surveyor will watch. If they see sort of the same comments over and over and over and over and nothing individualized, that means you've given them an opportunity to dig deeper into documentation. And I've never seen a perfect chart. In fact, I've always said, if I see a perfect chart, somebody's lying. So you need to make sure if you are seeing it, a surveyor is going to see it. You do not want them digging deeper. If you could have handled this, at least from a documentation standpoint, on a surface level. So the and principles of this are both physical and emotional safety for patients and staff. It does ultimately help build trust, and that trust factor, the language there is really directed at long-term care and skilled facilities because they have patients much longer than usually our swing bed stay is, but it's the same rules again. And it means that your staff needs to be able to recognize signs and symptoms of trauma and what that impact is, not only in physical health, but mental health. And so your job is not only to capture it on a baseline care plan if there is past trauma, but also then team discussions on how you avoid re-traumatizing a patient. My best example for this right now is I've been around nursing homes long enough that when I visit a nursing home, I can tell women that have lost a child almost automatically. Sometimes they're carrying a stuffed animal or a baby doll, but it's also the way they move. It's when they see kids, how they react. It's pretty obvious. So their trauma was, if they're in a nursing home, long, long, long ago. But the fact is it can re-traumatize because it brings up memories for them. And as we age, sometimes our early life memories and our current age don't always separate that well because there's emotion attached to it. So those are the sort of things that we are looking for. The history of trauma, I'm going to let you read this when Becky sends out the handout, but I wanted to go through a couple things. So I'm going to start, and this is for nursing homes because this is where we have the most research at this point, since this has really only been in effect since 2018. But it is a huge population. I will be shocked if there aren't 95% of you on the phone call that have some kind of trauma in your background. I could take it probably to 100% these days because I include pandemics in trauma. People have lost their jobs. People have been very sick. They've lost close ones, people that are close to them. They've been isolated. There are all sorts of reasons. So there's a lot of trauma. And we still have, for instance, though we're losing this population, but we do have Holocaust survivors in different parts of the country. We do have those that have survived that kind of trauma in other countries where there has been a war and they've come to the U.S. for refuge, which means that sort of trauma can still be seen in the U.S. Obviously, physical, sexual, and mental abuse, which can be past or current. If you think about abuse in an abusive marriage, for instance, abusive parents that are still influencing an adult child. So there are a couple places where anybody investigating this would go look for your documentation immediately. So first is going to be your H&P done by the attending physician. And most of us are going to get in trouble there because at least many of the H&P assessments I see are almost, they're textbook, they're almost stamped. There's very little difference except for the specifics on, the medicine a person's on, maybe the list of ICD-10s, but the responses the physicians are filling in can be very limited. So let me remind you, one other group that we need to train on this is any physician working with a swing bed patient and or a long-term care slash SNF patient. For those of you that are in nursing and those who would be doing more physical work, that can be PTOT as well, then there can be signs of physical trauma. That can be scars, that can be bruising, all of those things that would alarm us about seeing it on a child coming into the ER. We need to be looking at for an adult coming into a swing bed program. Then there are the other third area would be a significant risk seen through the diagnosis is anxiety and depression, which I can tell you now is really off the charts because of the pandemic, but certainly anybody that's had longer term diagnoses pre-pandemic with anxiety and depression codes, alcoholism, use of prescription meds, use of street drugs, those would all be indicators that something's not right. And if you take what an attending physician could and probably should be writing if he or she knows something, what we are seeing from how a patient's reacting, like you're not able to move quickly towards a patient, or we see actually physical signs, and then obviously any of those diagnoses, that package of things should be an automatic key in that we should be following whatever our protocols are in our program to address individual needs for these patients. All of the federal government, the Medicare, CMS guidelines for trauma-informed care come from Substance Abuse and Mental Health Services Administration, which is also a division of CMS. So for one time, they tied together. We're not seeing one set of rules in a government, a determined area, and then something else being followed by our documentation rules. They are the same. I have this list because it's really the first things that you should be basing your training on, and probably your any of your principles and guidelines and other things that you have to have in writing. So the current one, the first one to start with, if you've not done it, are the 3 E's, and that's the event, experience, and effects, because that's what you would document. If you can figure out what the event is, then you'd want to document that, what that individual's experience is, and then what's the impact. People can go through a pandemic and be anywhere from drinking too much now to choosing to walk and not show as many signs, but mentally they've been challenged because of job loss or other areas. So the 3 E's are the first area. And if you follow into a fully developed program, which from 2018 now to 2022, we probably should have moved through some of these other lists. They are published. I've given you the guideline down there at the bottom where you can go and find them. So your team should be trained on the assumptions of this. And then there are principles that you should be following, and those are listed out at this website. And ultimately, you want to understand that there are multiple domains that are impacted by this, and this goes to your policies. And that goes to your skilled, meaning your swingbed policies, and or it could involve your overall policies. Remember that leadership is not exempt from being trained in trauma-informed care. If you were in a nursing home, the nursing home administrator, the DON, everybody would have to go through the same training. And even though hospital personnel can be removed both literally and figuratively from a swingbed program, they should be going through this training also. So this is the basis for where you should not only start and continue building your program, but a good way for you to double check to see if your program is sufficient enough to cover the areas of concern of the federal government. A short list here of childhood trauma. There are so many more areas. It's just not related to one thing right now. But if you look at this list, it is pretty extensive, and there are very few people, honestly, that I've run into that don't have pieces of it. So let's just start with bullying. For instance, I was not bullied, but I had a very close friend that was bullied. So it impacted me. One, because I kept trying to defend him all the time. I was one of those kids that was like 5'6" and 200 pounds when I was in second grade. Not quite, but I was much larger than anybody else. So I didn't get bullied, but I had a friend that did. So it impacted me too. So like I said, childhood trauma doesn't end up in one area, whether somebody was physically abused at home or not. There are other settings where that has occurred. So I would point out number 9, the refugee or the immigration these days of more. I saw a number of the percent of non-speaking. English is not as a primary language in this country, and it's amazing, even state to state. And that probably is one thing that you should be looking at, which is what is the percentage where English is the primary language. And even as people assimilate into our country and our culture, they are usually bilingual in their home. Even growing up in Connecticut, I went to school with kids who spoke English in school but spoke Italian at home. And they had 3 generations living in their household. And we still see that in different pockets of our population. So what are the reactions? Obviously, emotional is often deeper and causes more harm, and sometimes is harder to diagnose until we have something that comes out physically. Those of you that work in the ER, you know that can be irregular heartbeats, that can be stomach pain, as well as anxiety and depression. So physical somatic reactions, behavioral reactions that are beyond sort of what we would consider normal for an individual, whatever normal means these days. And then cognitive reactions it can lead to memory impairment. A lot of kids that were abused will have missing years. They can't talk about who they were when they were age 9 and 10, for instance. It can be very specific time periods, and that should be a key in of itself that something pretty substantial happened. Now, that doesn't have to always be physical abuse. It can be something that traumatic. For all the problems we have with fires, tornadoes, hurricanes, earthquakes in this country right now, there is a population of young kids that are being impacted by those natural disasters that we may or may not understand until they are older. All right, so the next thing is you're supposed to come up with a score, a way to determine at admission and during a stay in skilled nursing, and that means your swing bed stay, of what an indicator is. And the one that's being used most often across the country is an ACE score, which is just just shows that there is greater risk. 64% of the people in the country prior to the pandemic had an ACE score of at least 1. And if there's 1, there's an 87% chance that you have 2 or more. It's just not getting recorded. And again, prior to the pandemic. So the more ACEs there are, and it's a score of, from 1 to 10, then the greater risk you have for physical diseases, mental illness, and other things going on. Now, why I say that we're having trouble nationally with this, because the ACE is generally very specific to more of a pediatric review, but we don't have anything that has come up nationally yet that anybody seems excited about that goes to the population that we more often will see in swing beds. So in nursing homes, we are looking for a tool that might be better for an aging population, 65 and over. But with swing beds, we can get anybody technically from 20 to 100. We're more likely to have people maybe in 30s and 40s with some of this, but we are very likely to have 50 plus aged patients. So what is missing from this are these stressors, and you might want to take a look at this list and see if however we're doing our interviews, or however when we suspect something, that we are trying to get to the bottom of what the stressors are. It includes things like poverty. It certainly includes racism. It includes other types of discrimination. One of the things I think I have on a later slide, but we have a lot of religious discrimination in this country, and that's even prior to what is going on in New Mexico right now. But it can be smaller populations of that. So anything that's causing it, and you see one of the things there is lack of services. So again, it goes to social services. Protective factors. What are our communities doing? How are we working as individuals and in our workplace, particularly in healthcare, on skill building opportunities? And then what are the individual differences? So the people that come through trauma are the ones that found somebody that gave them a second chance. And often for kids, it has been a teacher. And as adults, it can be a religious leader, it can be a best friend, it can be a number of things that can help someone. And I will say that I put in there, because of the teacher, a lot of kids that have the ability to come into adulthood not showing trauma are the ones that were exceptional students or exceptional in competitive sports, because that's the way they stayed okay. And that's the way they hid whatever was going on in their homes. I put barrel rider because one of the best barrel riders in the rodeo circuit in the country for about 25 years was a victim of childhood abuse and eventually spoke out about it. So there are lots of things that we can be paying attention to see if that's a coping mechanism. All right, so the federal regs also go to critical access. So for instance, I know you do not have to complete the MDS, but Becky will have to go back and count up how many times I've suggested that critical access use the MDS as a training tool. And this is one more area where it's absolutely necessary that you look at the sections on the MDS, particularly A and some of those that go into mental health questions, and see if those are questions you can adapt into how you are looking for difficulties with patients. So there are increasing changes in our demographics, and we've got racial and ethnic diversity. We also have religious preferences. So I'm pretty sure, if I remember correctly, maybe even Adams County. I'm not very good on this, Becky, but I know Indiana has Amish population. Amana, which is a different, it's not Amish, they started at different times in history. Amana, we have Latter-day Saints in multiple states out west. We have Native American populations that may use different religious sources, may use different languages, may have things culturally that separate them from what we would consider mainstream America, for instance, whatever, again, that means these days. But we need to know our own communities. By the way, Quakers are another group. I've just worked with a In fact, I sat in on a town hall meeting with Quakers in a small hospital system so that they could understand what that religion wanted from healthcare and needed from healthcare. But in the MDS, there are tools there where we should understand what that person's culture is, and does that require us to assess further, speak with them more, speak with family members to understand what are important. And then you get into the social political issues, and right now in our country that tends to be significantly focused on race and ethnicity differences that we have, so that may be impacting your communities and impact not only somebody coming in on an emergency basis. We have people that are slow coming in for health care because they have worried about their ability to speak English or their insurance and or their race and so forth. So you all know your own communities. And the other piece is that we're supposed to provide an interpreter or someone that can speak and translate in a preferred language of an individual. When I go back to the prior slide and look at the number of people where English is not a primary language in the United States, we need to make sure that we are addressing that federal requirement, because obviously language barriers and cultural barriers keep people from answering questions honestly and completely that we need to know if we're going to address this care with an individual. The populations, again, I've talked a little bit about having unique cultural characteristics. Language is a huge one. I didn't mention, which I'm glad I have it highlighted, sign language, that we need to be able to have somebody that can translate, and then whatever those values and preferences are. The reason I have this slide in here, if you go to that bottom note, you will see those F tags again. F 552 is the right to be informed and make treatment decisions. And if they don't speak English clearly or understand English clearly, we have a deficit for somebody to understand what a swing bed is and what their services they're going to receive during that stay. They need to have a notice of rights and rules that we would provide to every patient coming into our hospital. That's been federal rules since Moses was on earth. But the bottom line is, do they understand the paperwork we're handing to them? I will tell you that I was in the hospital last year when case managers were standing about 25 feet from the bed. I had a case manager actually hold up a piece of paper and said, "I signed your name for you," which didn't sit well. And by the way, I was on the board of that hospital, so that got addressed pretty quickly. But, so much of the paperwork they put down on the bedside table because they couldn't get near us. And then you expect somebody to read all 30 pages and understand it. And I work in healthcare and I had to read it slowly. So there's a lot where we have to make sure that we are helping people comprehend what the rules are. And then F73 goes specific to having access of copies of records. So you can see the F tags can get down into nitty gritty too. We've provided a list before, and Becky, if somebody asks for it, I can send you the list of the current F tags at some point. I would say at some point. You're going to ask for it by the end of the day, so I'll think about sending it to you by then. All right, so what does non-compliance mean? So I'm going to go back to the F tag 699, which means specifically that you have failed as a facility to identify cultural preferences of residents who are trauma survivors, and I will just shorten that you have failed to identify cultural preferences of any patient coming into your swing bed, because you may not know at that point whether they're a trauma survivor or not, that you have not gathered the past history of trauma or triggers that may cause re-traumatization. This is another kind of personal story, but 4th of July parades got fireworks going off, and in our small town had fire sirens, from fire trucks in a parade. And the reason I'm bringing that up is actually that's how I figured out my son was deaf, because when he was 3, all the rest of us were covering our ears and he was not. So there are a lot of things that can cause trauma or set off trauma in individuals. That investigative summary, I put it on here because there's a series of in skilled care called general critical element pathways. They're very, very specific. It wouldn't hurt for that to be provided, but there is a a general one that you can follow to make sure that you are eliminating or mitigating any re-traumatization and or original trauma issues that you have to have while the patient's there. But those pathways called CEs are very helpful when you get into some specific areas in skilled nursing and you're trying to get ready, for a site visit from compliance and or survey team. This is the federal regulation. Remember I said 483.25 section M. So there's the whole federal regulation on trauma-informed care. And when you see this, you've got to remember that long standing in the skilled nursing is that it's always supposed to have been person-centered, and we're supposed to honor that resident's or patient's choice. So I have put that down there highlighted so that you can make sure that you are addressing differences in the patients that you routinely see. Also in the federal regulations, this has listed culturally competent federal regulations that are in a different section, still in the 483 codes. But here you go, where you have at least 37 million adults speaking a primary language other than English in the U.S. And these facts are about 5 years old because that was the last I could find. You have almost half who speak English not very well. And then that leads to the barriers that are causing confusion about why they're in skilled, what they have to do to keep themselves healthy, measuring patient dissatisfaction. And more importantly, I think for us is if people don't understand what we're saying, then they're not going to adhere to changes. We already have some stubbornness among all of us. If somebody tells us to, at least when I was a child, told parents to stop smoking, there was a lot of rebellion there. I've been told about 5,000 times about what a healthy diet is for me. I don't exactly follow it every day. That's my rebellion. So again, that's a lower quality of care that we're ultimately providing if they do not understand what we're saying to them. And then again, this is for the Federal Register R, but it's an F code, which we talked about, and that's again the federal regulation, what it says. So your program at this point, technically in 2018, certainly by 2019, should have had documentation of policies that are specific to trauma-informed care. Your staff should have been totally trained in 2018. It was actually at the end of 2018, so I'll give you till 2019. We should have documented patient interventions that we have done based on the trauma-informed care, where somebody has not had a primary language as English, or somebody doesn't understand what we're saying because of language barriers as far as specific health and safety issues. We should have documentation of what we are doing and what we have done in the past, so that they can see that we're in an ongoing, not only providing trauma-informed care to our patients, but training for all of us that have to work in healthcare. So there is some specific, and remember when you see resident swing beds, it is patient, it's federal regulations. So here's the baseline care plans, which is now the key to person-centered care, and person-centered care goes to trauma-informed care. Remember that culturally competent. So I highlighted here dietary orders, because when we get into different cultures and religions, that's where we often find dietary differences in those being admitted to our hospital and to our swing bed. So that might be a discussion that you have internally. I don't know, you can look back the last couple of years and see that the patient base of who you admitted, and if there's even one individual that's been admitted that has different dietary concerns, then that means that we should have some warning set up, and we should have some training for your staff that work with patients every day to pay attention to someone that may not have clarified that well when they came in, and may not be eating well now because they can't or won't eat certain foods or drink certain liquids. This goes back to the baseline care plan leads to a comprehensive care plan, and it has to be developed within 48 hours of a patient admission. 48 hours these days is by time. So I've said before, if they come in at 3:30 on Friday afternoon, that means by 3:29 on Sunday afternoon, your baseline care plan must be in place, and your staff should be trained to that. So there's a list of the goals that the patients want, and some of the other things that would be very specific to trauma-informed care and culturally competent care, and person-centered care, all languages that CMS is using in our patient care these days. So here's what I'm going to ask. First is you should ask yourself if you've had trauma-informed care, and a statement. Every one of you working with a swing bed should have been going through a program, an ongoing program on that. But has it been completed for any staff coming in contact? Now think about that. That's not just those that are nurses and not those that are PTOT speech. It goes to administration, it goes to maintenance, it goes to housekeeping, it goes to potentially coding and billing. Again, understanding, all the way through the system. It goes specifically to physician education and documentation. I'm finding a pretty good lack of education being provided to our providers in our small communities. You should have policies in place. And finding policies for trauma-informed care is not easy. This is not an internet search where you can drop into them easily. And Becky, that may be something where you guys want to talk about sharing policies between your hospitals to cut down some of the legwork. And if you share them, sometimes you may have had a policy in place, but you see that one line or that one paragraph that would fit very nicely into yours, so it helps everybody. And then what are the triggers that are most noticeable with the swing bed patients? You actually should be asking your team that once in a while, because the survey will ask them, what triggers do you look for? What things do you notice, with patients when they come in that might lead you to think we need to do a little more homework on what their background is or what issues they may be having. Certainly if they have certain diagnoses, that should be something for your team meetings. So any patient with anxiety and depression would be someone that we want to make sure that we are addressing what sets them off. And that has been extraordinarily complicated these days because of a pandemic. So you have to spend some more time with that. But certainly deeper cases of depression, chronic depression, so forth, we might be looking at those diagnoses more carefully, at least mentioning that we have reviewed that in our notes so that everybody knows that we're doing it as comprehensively as we can. I will tell you the other thing they can look at is in your IDT team notes. Were there discussions that have been documented on trauma-informed care issues that you've seen in a particular patient or patients? And did that care plan reflect those approaches that you've taken to take care of that patient? So they can go to your care plan, they can go to your IDT meeting, they can go to your physician documentation, they can go to your daily documentation, and they're going to discover pretty quickly how comprehensive you have integrated trauma-informed care into your provision for providing services to swing bed patients. So I would challenge you to go look at, 5 charts, 10 charts, whatever you want, and look and see if you can find anything that could go directly to your interventions on at least asking, if not addressing, trauma-informed care types of questions. So Becky, I think that's a lot to take in, which is why there's a lot in writing in this. I will tell you that I have provided an extensive list of resources for this that might help you find things where you need some additional information. I even have some policy samples. They're not specific to swing beds, but give you an idea for those groups. Michigan seems to be the most comprehensive one in addressing what we might have to have for policy for doing trauma-informed care. So I don't know if there are any questions. Becky, I think one of the questions is, without putting the onus on anybody, how many of them feel like they have a comprehensive trauma-informed care program going at this point?
Yeah, please chat that in if you feel like you do. I know we have shared in the past and self-assessment that was from the National Council of Mental Well-Being. It was actually originally developed for primary care, but it translated very well into a self-assessment for critical access hospitals too. So if you need a copy of that assessment to really kind of identify where your gaps are, let me know and I'll be glad to get that to you. Likewise, in the follow-up email with the recording to today's event, there are a couple of toolkits out there that others have found to be helpful. And some have some pretty good links that they have used to some videos that have provided some good education to share with staff. So I really kind of encourage you to identify a champion there at the hospital that can kind of lead the cause around trauma-informed care, and make sure that you have good resources that if a patient were identified, what are staff's next steps and providing assistance to that patient. So questions, you can chat them in, you can unmute your line. If you feel like you have implemented a good program, I encourage you to unmute and share that too. And we'll just pause here for a second. Likewise, SAMHSA has some really good resources out there on making sure that you have tools and resources that you need to fully implement good trauma-informed care at your hospital. And Crystal shared that they ask trauma-specific questions on admission and also address the same questions that are on the MDS. Not all staff have completed training, which I think that's a pretty common statement for most of our hospitals that have been trying to get that implemented. She also shared that she's completed the IU Health Free Trauma-Informed Care classes and will update the plan of care based upon the comprehensive assessment. And yes, that IU Health, I had forgotten about that particular resource, Crystal. I shared that probably 4 years ago with individuals, and I will go out and I will share that link again as well. But it has several modules, and what's nice about it is it's a self-paced program and used to be pretty easy to pick up where you left off. So if you got interrupted in the middle of a module that you were completing, it was easy to go right back to it. And Crystal said it is still available. So thanks for that. I appreciate that. Any other questions? And there is a statewide collaborative. It's actually for the primary care groups as part of some of their grant funding that they are required to do, but the state has invited critical access hospitals to be a part of that collaborative to learn more around trauma-informed care and implementing it well in your organizations. And they do have some in-person learning sessions coming up later next month. I believe that's all we have for today, Carrie. I know that people are really trying to work to get it implemented well and in their organizations. And, you know, it's one of those areas that's just a little bit difficult to really get your arms around and feel like you have a good program in place, particularly with the limited resources of behavioral health providers right now.
It is, and that I think is important why, at least in the assessments and our documentation, we're showing what we're working on. You know, we may not be to the all-inclusive perfect world yet. In fact, I don't know many people that ever will be with mental health issues, but it would be if we have not identified, if we've not done our basic level, that's probably where the trouble will occur. So if we find something significant, I have no doubt that either the ER or others have resources where we're referring people or even transferring them to psych type of facilities if that's what is required. But it is on a daily basis, you know, that our staff has been trained, that we're paying attention. And as a reminder, again, any staff that works with at any level in a swing bed or skill facility also has to go through this training as a requirement, because part of that is the re-traumatization of the staff. It was equally important when the government set this up as to the patients being re-traumatized.
Yes, and even as you're providing education in the hospital, leadership should be very aware of, as education programs are provided, are there triggers for staff members? And so always something to keep in the back of your mind and make sure that you have good steps in place for staff as well. Okay, well, I think that's everything for today. Glad to help everyone identify resources that you may need or suggestions, or if you want to talk through your program, we're always willing to do that. So take care, stay safe, and let us know how we can help you implement a stronger program. Thanks so much. Bye-bye.